Welcome everybody. Really fabulous to have you join us for the third of our webinar series. There are a series of webinars on the topic of digital health, and really we've been thinking throughout the webinar series about how industry, startups and SMEs, how the NHS and how academia can collaborate on a range of different sort of themes. And the theme we've got today is evidence and evaluation, and we're particularly thinking about how to design and develop digital health products and services with evaluation and evidence in mind, and how we gather impact. So we'll be bringing an SME perspective, an academic perspective and an NHS and a policy perspective as well. Yeah, so I'm going to invite Stephen Potter, who's on the call, to just do an intro to pitch in, and then we'll do an intro to the panel and myself. So thank you, Stephen, over to you.
Right. Good morning, everyone. I hope everyone can hear me loud and clear. My name's Stephen Potter. I'm a researcher at the University of Sheffield, and I'm going to give the brief overview of the Pitch In programme, which is the sponsor of this series of webinars. And I've got two hats on, really, because on the one hand, I've been working on some of the health-related projects within Pitch In, but also I've been helping to manage the overall program. So I see all aspects of Pitch In. And Pitch In stands for promoting the Internet of Things via collaborations between higher education institutes and industry. So it's a slightly contrived acronym, but it summarizes basically what we're trying to do. It's work to investigate barriers to the uptake of the Internet of Things technologies and of digital technologies more widely, and then to share the lessons learned, and all for the benefit really of the UK's industrial strategy. And the work's been funded by Research England's Connecting Capability Fund, that precise purpose. The programme led by the University of Sheffield and also includes the Universities of Cambridge, Newcastle and Oxford, plus various external partners. Just in case anyone's not familiar with the term, by Internet of Things, we mean the use of networked sensing devices to share data about people, things, processes, what's going on in the environment, basically. And then to use that data to manage or try to improve the state of affairs. And we've been working in 4 sectors that we identified right at the outset as being key, really, to the UK's industrial strategy in this area, which were energy systems, smart cities, manufacturing, and health and well-being. And it's in that last theme that we're presenting these webinars today. And within the sectors, a lot of our work has been based around the idea of what we call mini projects. We've had nearly 70 of these. They're collaborative with industrial and third sector, NHS partners. But the idea is that in each of these mini projects, we investigate one or more of the barriers to the uptake of Internet of Things and digital technology more widely. So in the health strand, we've looked at the use of Internet of Things in care homes and hospitals, its use in social prescribing, for promoting positive mental health, for promoting exercise in schools, for remote monitoring and diagnosis of sleep disorders, things like that. But it's not just the technology, it's all aspects really of the use of technology. And one of the key things there is really what's the business case? What are the economic models that support that? I think that's where today's session is going to be really most relevant, because of course in the health sector, the business case, the economic models are intimately related with the value that the technology provides. And that in turn is linked to the outcomes for for patients, for the public, but also for the health systems and services themselves. So I think those are some of the things that I hope we're going to hear about during today's session. These webinars also fit in with the wider pitch and aim of sharing knowledge and experience and encouraging best practice and cooperation around these technologies. So just to conclude, once again, I'd like to thank Kat Easton from the University of Sheffield and Victoria from Mindwave for devising and organising these webinars. And I'll hand back to Victoria. Thank you.
Thank you very much, Stephen, and we really appreciate the support from Pitchin to be able to run this webinar series and the hackathons that are going to follow. So we'll start with some introductions. My name's Victoria Betton, and I work for a digital health company called Mindwave. We're a spin out from South London and Maudsley, and we have a personal health record, and we help the NHS and charities build digital products and services for sort of social impact. So my background's NHS. I ran an NHS hosted digital consultancy for many years, more recently worked in industry, had a brief flirtation with academia when I did my PhD, but didn't hang around. So my real interest in this is having worked with tons of SMEs over the years, really seeing that people often don't think about evidence until way too late. They don't even understand, if they're not clinically led startups and SMEs, if they don't understand the role of evidence, they start thinking about it way too late. So in my previous role, we used to work really early with companies at prototyping stage to help them think about the sort of evidence and data they would need to help them prove that the claims that they were making were justified. So yeah, so I've seen things not work because of lack of evidence and not having thought about evidence, and that really sort of drives me. And while I'm so interested in this particular webinar today, and I guess Kat and I came up with this the idea for this series because we've known each other for a while. And we were sort of scratching our heads about how we can help collaboration between industries. So that's sort of how it came about. I'll invite each of the panel members to introduce themselves and just say a little bit about why you care about this topic, why it matters to you. So Kat, can I invite you to start, please?
Yes, I was looking at the chat. I got really distracted then, sorry. Why do I care about evaluation? I care about people that will be ultimately using some of these products or services, which for me is most often the patient. I care about them having trust and faith in the systems that we're creating. So I care about evaluation because I want to make sure that things will do what they say they will do on the tin.
Nice, thank you, Kat. Ilse, welcome.
Thanks, Victoria. Hi, everyone. My name is Ilse Parry. I'm a user experience researcher at Mindwave. My background is in industrial product design. I spent 16 years focusing on approaches and methodologies in the development of creative solutions to problems. I've had some work experience in healthcare from a clinical perspective many years ago as a student. I worked as a clinical support worker in a hospital in Manchester. So I'm really interested in the development of healthcare solutions, which is why I moved into digital a few years back when I undertook the role with Mindwave. And I've also worked in academia. I spent 11 years as a senior lecturer at University of Lincoln. I care about evaluation more than evidence, I think, because the insights that are derived from the research that we carry out represents the meaning really and the impact or the true value of any design that we create to someone's life and their personal objectives from a user perspective.
Thank you. Abigail, tell us about yourself. Welcome.
Hi everyone, I'm Abby Millings. I'm a senior research fellow at Sheffield Hallam University. I started my career as a social psychologist, looking at relationships and how they affect well-being. But I was always interested in how you can apply knowledge to interventions for well-being. So from there, I kind of went on to work on a large-scale randomized control trial evaluating CBT. Because I wanted to learn about CBT, I ended up learning a lot about trials and evaluation and how randomized control trials work. but I was still wanted to know about CBT. So I then kind of moved into digital because I also wanted to know about how we could use technology in interventions. And I worked for a company that made, as it was known back then, computerized CBT. And it was the first one to get NICE recommendation back in the day. So I designed intervention content and trials to evaluate digital interventions, and then ended up returning to academia, which is where I've been ever since. And I think for me, why I care about evaluation is because I spend a lot of time as an academic thinking about theories, thinking about research, thinking about how we can put those things into practice in an intervention context. So then the really massive question is, does it work? I really want to know whether all this time we spend creating these interventions to try and help people, whether it actually works. So for me, that's the driving force.
Thank you, Abigail. And Jen, would you like to introduce yourself?
So I'm Jen Martin. I'm the Senior Programme Manager at the Mindtech Research Group, which is we're based in Nottingham. We're a partnership between the university and the local mental health trust, and we're funded by the National Institute for Health Research to try and increase the amount of work being done around digital mental health. So more development, more evaluation, more implementation, than to work with the NHS, with industry, with academia and charities and patients. And we've been going since around 2013. And I guess the sort of reason why I'm so interested in evidence is just wanting to see so many, these sorts of interventions that we've been focused on, digital CBT, digital interventions, virtual reality, more novel things, actually moving from the research and development space into use. I think it's a sort of an internal frustration for me to see how much time, effort, money, particularly taxpayer money, that goes into developing interventions, showing in an RCT sphere, or in a sort of quite a research environment, that they're clinically and cost effective, but then they never make it through into widespread use, and patients and society never gets the benefit of that. So I think that's what I'm most interested in. And I think, just reflecting what Victoria said, sort of similar experience really, of just trying to get people to take a broader view about what evidence is and what value is, and to be able to understand very early on what sort of metrics, what evidence, what information, what intelligence they need to be collecting about their product as they go along, so that they don't end up along the line either having not collected any evidence at all, or collected the wrong sort of evidence, and it isn't meaningful for the people who are really going to take a decision on whether or not to either use or purchase or recommend that product.
Thank you, Jen. That's brilliant. Stephen, welcome. Would you like to introduce yourself, please?
Yeah, thanks. So I'm a senior research fellow at the University of Sheffield. My background's in sociology, and I guess what got me interested in evaluation, then moving on to digital health technologies, was my first postdoc job. Was working on an evaluation of a national policy pilot. So I was working on the local and the national evaluation of that, and it became quite clear at an early stage that the people who were paying for the evaluation weren't actually that interested in what we were finding. And so I started to get really interested in the usefulness of evaluation and how we could design it so it was more useful. And moving on from that into using evaluation as part of a process from selection, design, innovation, implementation, scaling up, and so on. So it's kind of as a part of that end-to-end process of getting innovation into wider scale use. I've worked on the testbed project for digital health. I've been in the rehabilitation assistive technology group at Sheffield for about over 12 years now. Worked in the Centre for Assistive Technology and Connected Healthcare. And I was the lead evaluator for the digital health technology in the Yorkshire Number Clark for a while. So I think my interest is not necessarily in whether things work, because you find that quite a lot of innovations work somewhere for somebody in some capacity. So I'm really interested in complex interventions and evaluating the real world applications and innovation in context, and adapting that for the context to make it more efficient and effective.
Thank you, Stephen. You'll see we've got such a nice blend of sort of approaches and backgrounds here on this panel. Last but absolutely not least, Mark, would you like to introduce yourself?
Thanks, Victoria. I'm Mark Salmon. I'm a program director at NICE. I've had an interest in digital health for about the last 5 or 6 years. Started out as a bit of a hobby, actually, and got a bit out of hand. But I ended up co-authoring and co-leading the development of the evidence standards framework for digital health technologies at NICE, and I've been really interested in the way NICE is looking at different approaches to evaluation of digital health technologies and particular challenges they pose. And the value we can add as a national evaluator is providing advice, standards to the system, and really picking the right sort of technology suitable for national evaluation, where we can make a real impact to the health system and to patients. So that's been my interest.
Thank you very much, Mark. And thank you to everyone that's introducing themselves on the chat and starting to have a conversation. We're really keen that you have a conversation in parallel, ask questions, make comments, share resources. It's clear that there are many people on this call who have tons of experience from their own and from your own sort of perspectives and context. So really keen for you to chat with each other and chat with us there. And if you've got helpful resources or interesting stuff that you'd like to share, please put them on the chat as well. So I just thought it was just worth briefly sort of touching on the types of relationships, because one of the things that Ben pulled out actually is you sort of got SMEs and startups at one end needing to collect evidence to show their product works but not knowing how to do it. But then you've got researchers sometimes at the other end creating very good evidence, but then not necessarily having the right incentives or understanding to put something into practice. So you've sort of got two groups at completely opposite ends of the spectrum, and we need to find a way of making things work in the middle. So yeah, there's all sorts of different relationships, and this doesn't necessarily capture everything, but you've got tech companies such as Mindwave, who help researchers build products to gather research data. You've got tech companies building products to create a digital intervention that's going to be researched in practice. But you've then got academic projects that bring in tech companies and the NHS as partners. And I guess this bottom one is the one that we'll probably focus on the most, which is startups and SMEs working with academia and the NHS to generate evidence about their product or service. So the topic of evidence can start in all sorts of different places. And I guess what we're concerned with today is about, I think, a very pragmatic approach about how do you make some of this work in practice, capture proportionate evidence, and then use it as a way to get things that work out into the real world. So just wanted to briefly touch on a couple of slides about the sort of the life cycle of a digital project, and this is adapted from Nesta's innovation pathway. And of course it's not linear, anything but, because as Stephen said, all of this is mired in complexity. But broadly, it starts with exploring problems and challenges, having hypotheses, assumptions, identifying problems, generating ideas for how you might address them, designing, developing, prototyping, onboarding and engaging, and then delivering and implementing, and then generating evidence and sustaining. And I'm sure all of the panel will be horrified that evidence comes in right at the end, but that is actually in practice often when people start thinking about things. And I think our challenge is to bring that evidence piece right up when you're exploring the problems and the challenges. And I guess that just leads me on to the next slide. And this is something I'd like to just pick up with Ilse, which is a typical agile design and development process within a startup or an SME, when an SME is building a digital health product. And I guess what we talk about as research in industry might be quite different to what we talk about as research in academia. And I just wonder, Ilse, if you could just sort of take us briefly through this sort of process, but also really pull on that sort of discovery and user research and testing hypotheses, which I think are all the sorts of words that academics would use, but they might mean something quite different.
Yeah, I think I'll approach this from sort of layman's term kind of perspective. For anyone who's not familiar with this model, when we're designing and developing digital products, we tend to really use the discovery phase to ask some of the big picture questions around what is it that we're trying to achieve in developing a digital product? Who is it for? And what impact is this going to have to the users' lives? How many different users do we have in this context? And, you know, how can we add value, really? So it is a lot of qualitative research that goes on in that phase, and mostly consists of workshops. In the pandemic that's been online, we've used a platform called Miro to facilitate those. And we're tending really to have discussions and talk about people's everyday lives and where we can intervene to help them with a digital solution. As we start to then evaluate or analyze, let's say in the first instance, and draw out some high-level themes from the data that's come through, we think about what we can develop in a wireframe for a digital product and how that fits into a user's journey. And we do that within the alpha phase. So we're prototyping designs and coming up with some basic building blocks, really, of the features and outcomes needed to achieve what we've discovered. And then that moves into the beta phase, once it's been further tested and took back to the user groups for them to tell us in their own words what impact those solutions have for them. We refine them and take it into beta and start to build it so that it's interactive more fully. And then we will then give those staged solutions to the users to work in their own context every day. And then work out some of the bugs and any big impact issues that we've discovered in everyday use, and then through to live, where the product is there for people to use.
So what we're describing really is a highly iterative sort of process based on sprints, where you're identifying user needs, prioritizing requirements, and sort of building as you go and doing lots of sort of short releases. So that model and style of working is so different from how academia tends to operate. And I wonder, Kat, whether if we could just have the next slide, if we could just kick off sort of thinking about some of the challenges that we're facing in terms of evidence. One of the first things that strikes me, just thinking about Ilse's description there, is just how differently academia works compared to startups and SMEs. So Kat, could you maybe start off by commenting on that, please?
Oh, well, when you had that slide up before about the relationships, I suppose it depends what kind of approach we're taking with evaluation. So, for example, if a company comes to us and wants to work on a kind of consultancy basis where the university is evaluating their product or service for them, that's quite different to when we're all really collaboratively involved in a joint bid together. But one challenge I've always found when working with companies around evaluation, well, one of the things that I think Abby might be able to speak to more as well is thinking really about mechanisms of change and thinking about really what is that product intending to do, like what does it want to do, and how then would we evaluate that. But one of the challenges that I've often found is when working with companies is one of the things you need to develop is a great relationship. Obviously, evaluations don't just happen quickly and you need to have a good relationship. But then I also have to be really objective and say I have no vested interest in your product working or not working. Like I'm here just to simply identify whether or not this adds value to someone's life. So I think that's one of the big challenges for academics is we can't get invested if we're working on that consultancy basis, which is really hard because this is people's baby. If it's an SME, it's what they're waiting to get out, and they obviously think it's going to work. So that's a real challenge, I think, for me.
Thank you, Kat. And Jen, you wanted to come in.
Yeah, I was just going to say that I completely agree, Kat. That's certainly our experience too. Sometimes there's you know, this thing about, you know, the ugly baby. Nobody wants to hear that their baby is ugly, their product is not a good idea, and that is tricky. And that's where it is important to be honest and maintain your independence, particularly as an academic. But I think there's also a flip side of, and I think you see this quite a lot in academia, obviously mentioning no names, is that it's also your own baby, and you know, especially when evidence and research is so messy, you can do, you know, a study and really not find great results, but come up with all kinds of reasons why perhaps it wasn't quite right in this instance. And if we did this a little bit better next time, you know, if we just tweak this, then it will work. And really, you know, you might be flogging a dead horse. And I think there's also, you know, an element, particularly in digital, I think, of knowing when to perhaps stop or redirect. I think that's a real challenge as well, is, and you know, biases and incentives are all complicated and sometimes perverse, especially in academia, when it's easier to perhaps get the follow-on funding for something that's already got a bit of a track record, as opposed to give it up as something that's not going to be successful and try something else.
Thank you, Jen, and really appreciate your frankness as well, that there are these are almost like relational and emotive sort of challenges as much as sort of practical ones. We're going to get into a discussion about what even is evidence next, but Stephen, I just wonder if I could bring you in, because you talked about complexity, and I wonder whether one of the challenges is just that we're dealing with we're dealing with a lot of messiness, aren't we? And a lot of complexity. So could you maybe just speak to some of the challenges around that, please?
Yeah, so I think what's really required when we're dealing with a lot of innovations, it doesn't take very much for an innovation to become very complex. You know, when you start dealing with people, the complexity just multiplies. So I think it's you know, it's understanding the theory and the key principles and adaptation. I think those are kind of the key things that you need to think about when you're dealing with innovation in complex settings and complex innovations. Yeah. So I think people can get too hung up on the technology quite often, and not really focus on the theories underlying where it's going to work, why it's going to work, who it's going to work for, and you know, who might be interested in it, and you know, all the details around that sort of implementation, adaptation, and I think you really need to have those key principles really deeply understood and embedded in the delivery in order to have an innovation that actually is able to translate to other contexts.
I think that's I really, what you said about people getting very interested in the technology and elevating the technology above everything else really strikes a chord with me. And I remember interviewing a really successful SME actually, and who have a sort of an alternative to a pager that they're scaling in the NHS. And I asked the founder what proportion of success was down to the technology himself, and he said 15%, as in 1-5. He said it was all about system and process redesign. It was about culture, it was about leadership, it was about the organisation's appetite for innovation and ability to absorb a new technology. And actually the technology was a tiny bit of it, but it's the technology that tends to get fetishized amongst everything else. So I think that sort of, that resonates for me.
Yeah.
Abigail, what about you?
Oh, sorry.
Sorry, no, finish off, Stephen. Come in.
There's an interesting case in point with the test beds. So that was a national program to try out different ways of identifying you know, health technologies and matching those up with need, and then implementing them and evaluating them. But a lot of this selection process for that started off with the technology, and there were kind of, you know, marketplaces where, you know, people would go and select a technology and then take it back to the trust and say, you know, which of these technologies do people think is a good technology? And you know, I think that focus on the technology was quite a difficult start for the test beds.
And also quite supply driven rather than problem driven. So not the NHS saying this is what we need, but actually supply saying this is what we've got, which is maybe a challenge as well. Yeah. Abigail, would you like to come in? Any sort of particular challenges you'd like to pull out from your experience?
Well, as people were talking, I think one of the things I was thinking about is this issue of relationships with whoever it is that's made the technology when you're evaluating. And just to highlight that, probably in terms of randomized control trials, which are, you know, for better or worse, perhaps still regarded as a gold standard of sorts, the most rigorous way of doing that is to not have any relationship at all with the technology that you're evaluating. So even the funding for the trial would come from somewhere else, so that there is no bias, there's no vested interest in the results. For all of the reasons that people have been saying, it's, you know, it's very difficult to tell a company that's paying for the trial, those results that you were hoping for, they haven't come out right. Here's a failed trial for you. That's not going to help you at all. So I think it's just important to think about what kind of trial is the goal. And actually, not all trials are good. You can easily run a really bad randomized control trial, and it won't give you, well, perhaps it will give you the result that you hoped for, but that doesn't mean it's good research or good evidence.
You raised a really good point around sort of peer review and about quality of evidence. And I know that some digital health companies have been criticised because they've produced publications that actually they're designed to look like they've been peer reviewed, but actually they haven't. And actually the people who have written them are the people involved in, you know, have a vested interest in the product or the company. So I guess there's a question about how you get the right quality of evidence that has carries weight for the people who are going to be buying it, and gives them the right sort of evidence. So one of
the other things I was just thinking of, Victoria, because Abby and I have worked together on lots of projects in the past, and one of the other things I was thinking about when there isn't that bias there, when we're kind of coming in with external funding with a company, one of the other challenges is thinking about what the company thinks their product might do, like the way it might work, that mechanism of change. And as an academic with expertise in that particular area, how we would theorize that change based on what we know and all the literature and that kind of thing. And I think you're going to come to that actually quite soon about, you know, this idea of what is evidence, what are outcomes, that kind of thing, which I think would be really interesting to look at.
Thank you. Yes, indeed. That is what we're going to come to. But before we do, I just want to bring Mark in, and we're going to talk about the evidence standards in a while. So let's not get into them now, but I'm interested in the problem you were trying to solve. So what was the challenge you were seeing that you were trying to address in developing the evidence standards?
Thanks, Victoria. I guess the first thing is generally the lack of evidence that we see in technologies coming through for evaluation by the NHS, and certainly from the ones NICE sees. But you know, we scan across all of the kind of innovation award type activities, and we get involved in those because we're really interested in getting topics through those sorts of routes. And it's pretty much, you know, par for the course that that there'll be a very low standard of evidence being provided, even though the technologies on the face of it look fantastic. Just that very late thinking about evidence and evidence generation, and that was one of the main reasons that we thought, well, what can we do as an organization to help people understand in a kind of pragmatic and proportionate way what evidence is, and what the NHS is looking for, and how the NHS makes decisions. It's a big educational issue, I think, that pharma have got to, where there's that depth of understanding about how the NHS works. And I think, you know, medtech and digital are just on that journey, and it's how we support them. So that's the first challenge, the absence of evidence. And the second is that it's not just about the evidence, as people are talking about. You know, for us to make decisions on an output, other aspects of technology are really important, and I think we rely on other agencies to take care of them, like, you know, data governance, privacy, interoperability, technical stability. These things aren't part of what we do as an organization, but you've got to look at technologies in the round. Evidence is part of making a comprehensive assessment. So, that's another problem area, is how you get a rounded view on a technology before you implement it in the NHS. So working with other partners who've got those responsibilities and looking at where those standards are evolving is an area where we need to develop too.
Would like to move on, and people have been asking, what is evidence, and we've got different takes on it. And we've obviously got here, patient experience and outcomes, which is linked to efficacy, clinical efficacy. We've got safety, so is the product safe to use? And then does it do what it claims to do? What outcomes does it deliver? Now, I always think the whole randomized control gold standard thing that you picked up, Abigail, is really, every session I go to about, or conversation I have about evidence is like, oh, RCTs just don't work for these very iterative, quickly changing products and services. So it would be really helpful if you could, just for maybe startups on the call who aren't so familiar with RCTs, what is randomized control trial, and then where does it fit and where doesn't it fit in your experience or your view?
Okay, so if you want to find out whether something is working, then perhaps the most basic way you could do it is measure the thing that you're trying to change before people engage with your product, and then let them engage with your product for a while, 6 weeks, 8 weeks, 2 months, whatever, and then measure that thing again, and then look to see whether there is some change in whatever outcome you've defined. So let's say we're looking at depression. Now, that's a pre-post design, which is all well and good, but you don't know whether those people would have got better anyway if you got the positive result that you wanted. You don't know whether it's got anything to do with your particular intervention. So one step up from that would be to add a comparison group. So you would have the people that are having your intervention and also another group of people who are not having your intervention, and you would measure beforehand and then again measure after and look for change between those two groups, look to see if there's differences between those two groups. And that starts to get a bit better, but there's so many things that you need to do to make sure that that evidence, if you're finding the change that you hoped for, is still it is rigorous and reliable. And one of the things you can do is to randomly allocate people to conditions. So whether people end up getting your intervention or whether they end up getting no intervention or a different intervention in the other group, that is what starts to make it look like a randomized control trial. So you're randomly allocating people to either receive your intervention or something else. You're measuring your outcomes before and after, and then preferably a bit after that as well. So you might have a follow-up after a few months or a year or so. And very, very quickly, the more rigorous you get with this, the longer it takes, the bigger it is, the more expensive it is. So really, if you want to do a really good randomized control trial, you're probably looking at a couple of years' work and maybe £500,000, which, yeah, the resultant data that you get from that and the claims you can make are probably quite good, because you've got this sort of gold standard of evidence. But frankly, who has the time and the money to do that in the digital space when things move so quickly? So what you end up with is this thing which is regarded as a gold standard, but actually it's so unwieldy and expensive, it's not really fit for purpose in the digital sphere. But I think it's a potential problem to, I hate this phrase, but throw the baby out with the bathwater. It's a horrible phrase, but it kind of, I think it sums it up here. We mustn't lose what's important about trials, and it's having that impartiality. So preferably people evaluating the thing who have nothing to do with the design of the thing. All the better if it's not funded by the people that have designed it. So you're removing that vested interest, you're removing those biases. And I think it's important also to think about how you're measuring. So the outcome variables, so in the example I said depression, if that's what you want to measure, how are you measuring it? Are you using the right tool to measure it? All of these things we can learn a lot from the way that trials are conducted, looking at these kinds of things. So I think they've got a lot to offer, but I do think that in the digital sphere where things do move so quickly, it's frankly unrealistic to be expecting a trial, which is obviously why these new standards have been brought in.
Thank you, Abigail. That was a really nice way of sort of laying it out in layperson's terms. Stephen, I'm going to have to bring you in here because I'm guessing you must have a different take on this, because you're really interested in the sort of the wider sort of implementation and context. So it feels to me that RCTs seem very linear. They assume things are very fixed, but actually they're not being plonked into something very simple and linear. They're being plonked into this sort of complex environment. So and there'll be other factors that will affect their take up and use. So could you just maybe give a different view or about that sort of real world evaluation, what evidence means to you?
Yeah, I mean, excuse me, I don't really want to put a a kind of a pro-con kind of polemic on this, because I have been PI on randomized control trials as well as other evaluation designs. But I think the MRC process evaluation guidance for complex interventions, evaluation of complex interventions is quite useful in this regard, in that a theory-led process evaluation alongside a trial will help us to understand, when we get the results of the trial, what potentially was actually working, rather than just saying, it worked or it didn't work. We can start to understand around disaggregation, so who's it working for, in what contexts, and why, and really understanding the theory. Because I think randomized control trial findings on their own can be generally quite meaningless. And you find that RCTs are generally implemented in quite friendly environments, in places where it's quite easy to implement them, and they're going to be well received and work well. And as soon as you start scaling up, you find that the active ingredients just aren't working in the new context. And so you get what's called Ross's iron law of evaluation. There's other names for it as well. But the good results that you might find from an RCT, as you start rolling out, they would generally just decline as you venture out into more and more complex and more different contexts. So I think that understanding is really important alongside a trial. I mean, there's a lot of debate at the moment regarding the hierarchy of evidence, but I think that you should be using the right tools to answer the right questions. So it's knowing what the questions are you need to ask and what tools you need to answer those.
Can I ask you a question related to that? Because one of the things that I think is challenging for SMEs is, it gets called pilotitis, doesn't it? That you trial something there, you get evidence, but then you're expected to do it every time. But almost you're making the argument that is appropriate because every context is different. And the one way you've done the RCT is where everyone's really bought into it because they've been very invested in a big trial, I guess. So what's proportionate when something's being delivered in one context but then gets delivered in another and another and another? Do you need to generate evidence each time, or what's proportionate, Stephen?
I think a lot of it is down to the implementation. So if you've got effective co-design and implementation processes, you can include that context dependency into the implementation, but it's understanding what are the key ingredients, what are the change mechanisms, what's working and how. I think that's really important. Otherwise you can completely miss the point and implement something that looks exactly the same as something that works somewhere else, and it should work, and you don't understand why. So it's that why question, I think, is very important.
Thank you. And Jen, you talked about, and Kat mentioned as well, about evaluation. So companies coming to you and asking you to evaluate, help them evaluate products and services. So what's evidence? What's good enough evidence when you're working with a digital health company?
Yeah, no, I think that's the $64 million question, and I think it's something that has to be. You have to specify what's what sort of evidence is appropriate for what sort of products, and I think, or technologies or interventions. I think we've been focusing quite a bit on interventions, but I was thinking as other people were talking about other situations where the technology that you have is more facilitatory, or it's about redesigning services and allowing people to do things differently. And I think the sort of current situation with COVID is a really good case in point for things like video consultations for, say, well, any condition, but, you know, mental health is kind of my area. You know, all of a sudden there's every incentive to move everything online, and that happens unbelievably quickly. And, you know, considering people in mental health have been trying to get that happening, you know, for years, that's quite interesting. And I think it's about, I'm just reflecting back on a project that some colleagues of mine did at Nottingham, where they were trying to see whether or not delivering some sort of therapy for a particular clinical group could be done online. And there was real resistance from lots of different clinical staff. And, you know, there was lots of different aspects that they were thinking of, you know, ultimately, was it as good to deliver this remotely as it was face to face? That was the primary focus, obviously. But then all these other aspects then were sort of getting added onto the balance to sort of weigh the decision in favour of taking it up. And I just think, I mean, one of the things that I wanted to get across in this panel is just the NHS is a right funny old organisation. I mean, obviously it's thousands of organisations, but on one hand, you know, nothing gets done, nothing gets implemented without, you know, 20 RCTs, 3 systematic reviews, and a nice evidence of appraisal. And on the other hand, decisions are being made all the time based on, you know, absolutely nothing. And Mark alluded to that earlier on. But in this project, where it was around video conferencing, we heard for therapy, we heard feedback from one trust that the thing that really swung it in favour of them continuing with this was the fact that it allowed some therapists to work at home, and it had quite a big effect on car parking at the local trust. So so that was, they said that was kind of something that really was like, oh, actually, you know, we're seeing this in other benefits in other areas. And I think that's where at Mindtech, we sort of really think about this idea of a value proposition. Some of my colleagues are in the chat, Ashlyn Bergen and Jake Andrews in particular. This idea of, yeah, value. What is the value of your intervention? And it will have different value to different parts of the system. And you need to then demonstrate that value to different decision makers, you know, whether to purchase it, whether to use it, whether to recommend it. And you need to have build up a really comprehensive idea of what value is, what will be the evidence of that value, so you can then start to collect it.
That's brilliant. Thank you. You put the challenge in the NHS really well. Kat, we haven't talked about health economics, but I guess the ultimately the person signing stuff off in an NHS trust is the finance director, and they'll be interested in the money and they'll be working within constrained resources. So what about that side of things, about making the business case effectively? That's evidence, isn't it?
I used to like you, Victoria, but now...
Oh, sorry, was that
health economics. Well, I'm at Sheffield University, and we have, I would say, one of the country's leading clinical trials units and health economics teams in the School of Health and Related Research. So I just talk to them when we need information on that. But yeah, I mean, like I spoke about the AGILE project last week. So we did a feasibility study with that product, and then the really clever people in Charlotte do the maths basically said an RCT is just not required for this to go to market, and it would add no value at all in terms of the risks and the outcomes and the cost of the product and the size of the population that it would serve. That was really nice information to deliver to the company as well, basically to say, you know, what we've done is enough. And Steve was on that project, and he knows a huge amount more about that side of things than I do. But yeah, it's that was really nice to look at the economics of that and say, we don't need an RCT. This can kind of go out as it is. In terms of the business side of things, I don't know if people on the chat that are in companies might be able to say more about those business models. As an academic, it's not something I get involved in, but what I'm learning through these webinars is that I stick to what I know, but I do also have to try and understand all the other elements of this, like Jen's saying about value added and and all these things. So I really need to learn a lot more about this.
Yeah.
If anyone knows like a dummy's guide
to help. I mean, it's the real, that sort of benefits realization about how you're going to add value, but also potentially save time, improve quality, maybe even release cash. That's sort of the golden nugget that everyone's looking for, but often isn't achievable. The other thing I wondered about, I don't know whether you want to comment on this, Jen, is about theory informed or evidence informed or evidence based. So I think sometimes people talk about something being evidence informed because it's based on CBT, for example, but actually it isn't evidence-based because it hasn't generated its own evidence. So it just strikes me that we've got to be quite judicious in our use of language and not try and confuse or obfuscate actually what underpins a digital product or service.
Yeah, no, I think that's a really good point. I might say a little bit and pass over to Abby, because I think she will know stack loads more about this than I would. But I think that's something that we saw a few years ago in the particularly I think in the kind of real rise of CBT principles in apps and those sorts of things, where people were developing things and saying, you know, when asked about the evidence, we're just citing the CBT evidence, and that it was sort of basically informed by those theories. And I think, I guess it's that case of what's your product? Who are you trying to sell it to? What claims are you making? And I think those, you know, sort of well-being apps and these sorts of things, which are kind of in the low risk, low benefits, low cost category, maybe, you know, it doesn't matter too much as long as there's some sort of quality assurance, going back to what Kat says. And that's where I guess the NHS Health Apps Library and other app libraries have tried to come in. We're just giving a baseline of, we don't think this is, the information in this is harmful, but we certainly can't make any claims about its effectiveness or cost effectiveness, and allow consumers to make that decision for themselves. But I think where the NHS starts to come in, you have to do more, and you're expected to do more. And that's where I think then you've got to think about whether or not the claims that you can make justify the cost that you're putting on your device, the amount of investment that you're putting into evaluation, and what sort of, you know, income and revenue that you might want to take from that. But I might leave it there because I'm rapidly running out of my area of expertise, and Abby might want to add something to that.
Abby, would you like to come in?
Sure. So I think evidence informed, I guess that's where we start, isn't it? When we're designing interventions, we start with evidence informed. If we're doing it properly, then we're looking at like if we want to do behavior change, then we're looking at the literature to see what behavior change techniques work in the specific context that we're designing intervention in, and hopefully we find some nice reviews and meta-analyses which would identify those for us. And then we'll use that, and also copious amounts of co-design to make sure that we're getting the intervention right, and that we're designing the product properly. And all of that is evidence informed, but that kind of has to take you to then to evidence-based, doesn't it? Because you're not going to know unless you then evaluate it formally in the setting that you're hoping to use it in, whether or not those things translate. So it kind of takes you back to a trial again. Not that I'm saying that we should be, well, I think we do still need trials. I don't think they're always the best thing, but I said that before. But I guess one thing I would add about a trial is that a really well-designed trial will also have the economic evaluation built into it, and also the process evaluation. So a really great trial will tell you not only does it work in a particular setting, and yes, it might be the context of a very nice trial where everybody's bought into it, or it might be more of a real world type trial, but it should also be saying, is it cost effective, and what's the mechanisms of change? So if you design it well, then you can put all those measures in there and find out whether the behavior change techniques you've put in based on literature that you assumed were going to work on this particular thing, whether you've managed to change that and that's what's changed your outcome, or whether it was something else entirely. And I think that's really important for just moving the field forwards, because if we don't know how something's working, how can we improve it? I think it's really important to look at both of those things. And actually, one trial I worked on, the overall outcome of the trial was that the intervention didn't work, but it was cost effective, so yay. And of course, you need to know the answer to both of those things, and the process bit as well, to know how to move forwards.
Thank you, Abby. And before we move on, I just want to, there's been some really interesting comments about patient experience and patient outcomes. And I guess I've been thinking recently about patient-led innovation. So, you know, lots of examples of where patients or carers or family members have identified a problem that a clinician wouldn't even notice or care about, and they've innovated themselves to solve that problem for themselves and other patients. And when we're talking about evidence, we also need to be thinking about what's in it for clinicians, what's in it for the buyer, and that might be the more health economics bit of it, but also what's in it for the patient. And Kat, I just wonder whether you might want to comment on that before we move on.
Well, yeah, I think about this a lot, and Abby and I have had chats before when we, you know, back in the day when we were in Catch, about who is this for and what is the purpose of this product or service, and who is it really benefiting? Is it benefiting the service or the clinician? And so patient outcomes, especially when we talk to a lot of people with lived experience of mental health problems, which is my area, a lot of the outcomes that people want are quite functional and a lot more related to their quality of life, whereas there's that balance that has to be struck then between clinical services needing to report change scores on you know, the GAD-7 or the PHQ-9 and all these kind of validated measurement tools, where all of the literature and what I know from talking to people suggests that they hate filling in those measures, and it's not what they're looking. They're not looking for a 2-point clinically significant change on, you know, with their symptoms. They're looking for, can I get back to work, or am I able to go to the supermarket without having a panic attack? And so when we look at different interventions, we're thinking, what is it really that this is meant to do, and who is it benefiting? And like, I think Abby, I don't want to steal words from your mouth or misrepresent them, but we were talking the other day about people just, you're not going to collect data and get people to fill in scales and measurement tools if it's no benefit, it gives no benefit to them and their life. Why would they do that for us as researchers or the NHS? So I think it's the choice of what you choose, you know, that choice of outcome measures or how you think your product might work is really interesting, challenging.
Thank you, Kat. On that note, I'm going to move us on because I've been saving Mark for the next slide, if we could have the next one, because obviously NICE have attempted to create a framework and a taxonomy classification system for digital health to help guide the sort of decisions we make around evidence. Mark, we've done a little graphic that lays it out, and this is a tiered evidence. Could you talked a little bit about the problem you were trying to solve, but take us through the process and how you're hoping that startups, SMEs and researchers will use these standards.
Yeah, okay, this was back in, thanks very much. It's really enjoyed also listening to everyone, all the panel members there, some really, really good points. But yeah, we produced this in 2019 in answer to NHS England, NHSX saying, can you, NICE, with all your experience, produce some standards for this evolving market to try and guide people on levels of evidence? What type of evidence do you need to show to demonstrate something works and that something offers value for money? So that's what commissioners in the NHS are looking for. Does it work? And does it offer value for money? So that's what we set about doing. And the way you do things at NICE is sometimes more important than what it actually says. And so collaboration, really, really important. And so we involved 50 companies in this process. We did this over 6 months, iteratively evolving the content as we went. 50 companies and probably about 100 organizations in total, to be honest, in different workshops to get to where we got to. So these resources are all online on the NICE website. This is the Evidence Standards Framework for Digital Health Technologies. And what it's based around a very simple idea, a functional risk classification. So at the bottom of this inverted pyramid are the simpler technologies. So evidence tier 1 are what we call transactional type technologies, efficiency tools, things like booking appointments, more efficient ward management systems where there are no patient outcomes. So that's a level of evidence right at the bottom there. And what we do in these standards is then specify the types of evidence that we're looking for that's good enough to demonstrate that that technology works in a clinical setting. We actually try and describe the sorts of data and the studies that we need for technologies that fit into that category. And if you look on the NICE website, you can see lots of examples of technologies that we're talking about that fit into these different tiers. So you can see our thinking. So, and as you go up this, this inverted pyramid, you've got evidence tier 2, which are more about technologies that are about informing, communicating, and carrying out basic monitoring. So, you know, mother and baby first aid would be a technology that would fit into that. Chat health would be a technology that would fit into tier 2. Slightly higher level of evidence we're looking for there above tier 1. So we've specified that as an evidence category. And then the more sophisticated technologies, 3A, concerned with behavior change, where there's particular evidence that we'll be looking at behavior change models in the literature that we'd like to see applied in those technologies. And then up to 3B, these are the ones that NICE look at, the technologies that are about guiding treatment, carrying out diagnostic tests, or are tracking or measuring patient outcomes. So active monitoring. So these are all the technologies we think that the NHS is dealing with every day, and we've categorized them in this functional risk classification, with the kind of lowest risk at the bottom, highest risk in the top right, and then we've developed some evidence standards alongside that to say this is what we're looking for as the NHS. We're trying to get that using NICE's reputation as a kind of standard across the system that innovators can use in their dialogue with the NHS and commissioners can also refer to researchers, so it becomes a standard. So just to talk about the types of evidence we're talking about. So going back down to tier 1, we talk about things like making sure that you've got credibility with UK health professionals. Have you had UK health professionals engaged in the technology you're developing? Does it meet a need? Have you created a dialogue? Do you have a relationship? Is it relevant to a UK care pathway? So how does your technology fit in to the way care is being produced in the NHS and the system? Can you demonstrate that? Where in the pathway does it fit? Do you understand that? So evidence around that, very important. And you can see these are softer, these are not hard data things, these are softer forms of evidence. Is it acceptable with users? Really, really important. Are there any equalities considerations? Does it increase access? Does it reach a community we can't reach through traditional health approaches? Can you demonstrate that? Can you demonstrate that acceptability with users? Have they been involved in the development? Have you responded to the feedback from those users? So this is the category at the bottom. And then we build on that. So that's a base. And then we add to that as we move up the tiers. So into tier 2, where we're talking about communication tools, how can you demonstrate that the measurements are accurate and reliable? How can you demonstrate the accuracy of transmission of data if data is being transferred? How do you keep your information up to date? The content of it. How do you do that? Can you demonstrate that to us as evidence? Have you got any data to show usage in the intended population according to your value proposition? Because that's what we're interested in. And have you got data that shows value? Anything about user outcomes, user satisfaction? And do you have anything you need to think about in terms of quality or safeguarding issues? If there are children involved, for example, what safeguarding measures do you have What evidence can you give us around that? So these are just simple information tools, but you can see how the sort of categories of evidence are building up here as we move into tier 3. Where, as I mentioned, preventative behavior change category, smoking cessation, drinking less, eating healthily, exercise, prompts, particular evidence base around behavior change models that we're looking for. Do you know what they are? Have you applied them? Can you demonstrate that to us? And are those outcomes, what outcomes are you measuring that are relevant to those behavior change outcomes that you're seeking? And then it's only really in the 3B tiers, because we've tried to be kind of proportionate and pragmatic, looking at the whole market and saying, well, actually the sophisticated studies, which we do need, there are occasions we do need RCTs, but we do recognize also that there's the whole sort of real world data machine there in the background. So how can we look at the nature of the way studies are changing to help us make the judgments that we need to make is a debate within NICE. But we've only really specified RCTs at this very high maximum end of the 3Bs. But just looking for intervention studies with comparators, and we've given some guidance about what we mean by that. So in a nutshell, those are the sorts of categories of evidence that we've set out. We've put some detail around the sorts of studies and the type of data that we're looking for. And we've done that as a way into this conversation, this discussion about what is the NHS looking for, what do we need to provide as an innovator, and all this conversation about not thinking about it too early enough, because you can build these data collection mechanisms into your developing product. If you know what the NHS is going to look for at the end, you can have that ready and built in, using the fact that digital technologies lend themselves to data collection opportunities. And maximizing that, making that work for you. But I think that's a really important message, connecting with the NHS early, making sure there's a fit with care pathways that we're interested in, and knowing how to demonstrate value using metrics that we're interested in. I mean, there's another element to it which people don't always talk about, which we've also tried to describe, which is about the value proposition and the economic case. And this is really tricky, because if we get low evidence for effectiveness, this is about clinical effectiveness, this hierarchy here, it's even rarer that we would get really sound economic business cases that supplement a technology. And it's such an important area, the value for money aspect. And it's not just about the cost of that technology. It really is understanding the place in the pathway, being able to understand how the current pathway works, and with your intervention in it, how does it change, and what are all the impacts and costs that are going to be relevant to the deployment of that technology in a clinical setting. And that's what commissioners are going to be looking for, how you demonstrate that value. It might work clinically, but what's the cost impact? And there are different forms of analysis that you can use there. I mean, we use a cost consequences analysis, which at NICE, which is a bit further along than just what the baseline cost is. It's a sort of menu of costs and benefits in monetized and non-monetized units. So an increase in convenience will be relevant, or a reduction in anxiety, as well as the hard line costs. These are all relevant in considering what your value proposition is and what your business case to the NHS is. So we've also tried to provide you in using tools that we use at NICE with some kind of ways in about thinking about how to develop an economic case, what information you need, what types of analysis are important to think about, and how you report those also, what the reporting standards are. So I'll pause there, but that's a perspective from us.
Thank you, Mark. And I think you use the word pragmatism, and I think from a sort of SME industry perspective, just having something that guides you towards this is proportionate, this is relevant, this is where you need to start for your particular type of technology. It's just like a massive step forward from just a complete, no real sort of direction whatsoever. So I think, but I like the fact that it's not prescriptive. It's it's offering them to industry, and I think it provides a really nice compass for particularly from a company point of view. I just want to build on this to say, so that's great. We've got the standards, we've got this sort of pragmatic take, but who pays for it? And is it, and I'm really having a company perspective here, I guess. Who pays for the evidence to be generated or the evaluation to be done? And then will it, as a company, enable me, should that evaluation or evidence be favourable, to then scale my product within the NHS? And I'd really like to hear, because I think that'll be the that'll be the question in the mind of any SME that's watching or participating in this webinar. So who pays? Is it the venture capitalists? Is it Innovate UK? Is it SBRI? Is it a big research grant? Is it National Institute for Health Research? Who would like to sort of come in? Maybe Jen, I could ask you to start, because I know you do get approached by companies just wanting you to do an evaluation. Where do they get their money from when they're asking you to do something like that?
That is a really good question. From our experience, we've since Mindtech's been running since 2013, we've done a lot of partnerships with industry, and I don't think it's a coincidence that the ones that have gone the furthest have been the ones that have secured funding, and the majority of that funding has come from national innovation type pots, things like Innovate UK. The SBRI competition is really good, Small Business Research Initiative, I think, and then other things like, I guess, Nesta, Current Relief, those sorts of funding as well, especially for sort of more tech for social good type ventures. And then I think, I guess the real holy grail in some ways is NIHR and research funding, because I think that funds kind of more, bigger proportion of the costs. But I think the reality is that you're only going to get that sort of funding for interventions that are going to deliver real, big amounts of benefit to the country, to the NHS, to society, the kind of big hitters. And I think if you're working more in the, perhaps, I guess the well-being space, you've got to think, is this something that the NHS is going to pay for? And if it isn't, then you might want to look elsewhere. And I guess, that's quite interesting, where you see some of the innovations that are massively successful, things like Calm, things like Headspace, which have got so much money invested in them, I think, from venture capitalists. And, I don't know how much evidence they've collected in the traditional form, how good it is. I'm not making, I know lots of people use those and absolutely love them. I think another interesting product there I don't know if people have heard of Sleepio, but they spent a lot of time in the UK. It was developed from Oxford University, trying to, they had great evidence. They were trying to roll it out in the UK in the NHS. And I think eventually kind of realized that their markets lay elsewhere, because, they were really struggling to get traction in the UK. So I think it's complicated. That's not very helpful, is it?
Well, I think it's good to have that reality check, really, about where people might find money. And I guess before I move on, just my final question to Abigail is, we've got the RCTs at one end, but what should companies be doing in those very early stages? What are the sort of the basic things companies can do to get themselves in a position that, should they get grant money and so on, they might be able to do more substantial bits of research or evidence generation? So what are the fundamentals, I guess?
So I think it's something that Mark mentioned, actually, is embedding the ability to evaluate as you actually build your product. So because you can collect all this data very, very easily, you just need to ask, just as if it's easy, ask the right questions at the right time. And if you're doing that with validated measures, all the better, because then you've already got some kind of evidence building every time somebody's using your product. The issue with that, and I think it's a really difficult thing to balance, is the trade-off between needing to use reliable, validated measures in that way so that you're getting the data you need, and not overburdening your end user. Because in a digital product, if somebody's filling in questions, then they're probably expecting some sort of feedback for doing so. So you can get into a position whereby you've embedded measures because you want to have this data as you go along, but actually, if you're needing to give the user feedback on the way that they filled in those measures, then you're changing your intervention by including those measures, which that's not necessarily a problem, but it's something to be very aware of, and also to be very aware of what kind of feedback you would be giving people. But I think it can be really helpful to think about using standardized measures, and there are some short ones available, and to use it almost like a tracking tool. So if you want to get people to monitor their mood, if you do it with something that's validated, then you're building that evidence base as you do it, and people get to see, you could show them graphs of their symptoms as they go up and down, for example. So then you're kind of getting the best of both worlds. You're building something that's engaging for the end user, and it's collecting your evidence. So I think thinking about it early on and thinking about ways of embedding data capture in a user-friendly way is critical, really, because then you're starting to build the evidence as it's used.
Thank you, Abigail. If we could have the next slide, please, Roshan. I'm going to combine the last two slides together, which is one is around success factors and one's around pragmatism, which I think we've just touched on there, Abigail. But I guess what I'd like to do, sort of as we draw to an end of the webinar, is just invite each of the panel members to give some top tips, really, about thinking about how academia and startups, SMEs and the NHS might work together to generate evidence where it's appropriate in a proportionate way. What are the sorts of things that you think are, if you're going to start thinking about this, what are good things when you're thinking about that collaboration that would mean they would be more successful than otherwise? Kat, I'll invite you to start off and I'll go around.
What makes a successful collaboration with evaluation?
Yeah.
Well, I guess the things we've been talking about in the past two webinars as well, I think you need a good relationship and set expectations out from the start about what people's roles will be and what and when you will deliver that. So it's really transparent and clear for both. Well, not both, like as if it's just two people involved or two stakeholders involved, but so that companies and academics and clinical partners can really see what's happening within that evaluation and understand why evidence is being generated. I think that's important, that transparency.
And communication has just come up in each of our webinars, hasn't it? So important about finding ways to just keep a dialogue going and being able to empathise and understand each other's sort of
and it takes time. Understanding the different languages and how different sectors work, it takes a lot of time, and people like to communicate in different ways. I've worked with companies where they want at the end of each day a few bullet points on what's happening, or at the end of each week they want a team meeting, and it varies so much. And so it's really important, I think, in each of these webinars that we're looking at, discovery, relationships and this evaluation stage, to really have that super transparent.
Thank you, Kat. And Ilse, I know you've been very busy on the chat, and there's been quite a conversation about user research. So from a sort of small company point of view, what would your take be on and what makes for success?
I think I've been writing a lot of notes as Mark was talking earlier around pragmatism. And understanding what the evaluation is actually for, what's the purpose of it, why are we doing it, making sure that we're asking the right questions of the right people and generating the right evidence that's most meaningful for the context. Who needs this evidence and why is it needed? One good example I can think of off the top of my head is trying to convince patients to use a patient portal. The most pragmatic thing in terms of evidence to convince people for that was to produce a video of somebody using it, and a video of somebody that those users could relate to, who had lived experience in their context. And I think sometimes we get a bit too caught up in some of the methodologies and the acronyms, and pragmatism is key.
Thank you, Ilse. I think we can all sign up to that one for sure. Mark, from your perspective at NICE, you know, you've done huge amounts of work in thinking about this. What makes for success for you?
3 things from me. I think advice would be engage professionals and patient experts at an early stage and get that engagement. Secondly, generate evidence for the intended population, the care setting and the pathway. Understand it, and the key question, does it support the claims of benefit that you're making? Evidence around those claims of benefit. So, and then the third thing is, think about what is the value case to the NHS of your technology, and how you can best present that. So those 3 things are top tips.
Thank you, Mark. Abigail.
So the thing I've been thinking about is actually where you get your participants from for whatever study that you're doing. And it's a challenge in research, not just trials, but research more broadly. But I think it applies broader than that as well. And it kind of links with this knowing the care pathway and engaging professionals, because you can get very caught up in designing the product, but not really think about how it's going to be used in the real world. So there's an evaluation that I'm working on at the moment for a local authority. And one of the things we've realized that we're going to need to evaluate is actually how people get referred into this thing, and whether the people that we had hoped are going to refer are actually doing it. Have they heard of it? You know, so it's all that kind of pragmatic setting stuff is really important for designing your product, but also thinking about any evaluation moving forwards, because you've got to get people actually using it and get people willing to be part of an evaluation using it too.
Thank you, Abigail. And last but definitely not least, Stephen, what are your top tips?
Well, I think the NICE evidence standards are really helpful because it gives everyone a kind of a common object to talk about, and have a baseline for agreement on what an evaluation should consist of. So I think that's very useful in helping those relationships. I think there's 2 key things really that, so I run a short course called 10 Key Principles of Real World Evaluation, and I think there's 2 key principles that really speak to this. The first of all is the stakeholder engagement, so having a good strategy and understanding who your stakeholders are. And the second one is ensuring that it's useful, and these 2 things overlap. So you really need to engage with, find out who your stakeholders are, what their relationship is with the evaluation, and then engage with them to find out, you know, what will be useful from their point of view. And this can help you then drive your theory development and what evidence you need to get out of the evaluation.
Thank you, Stephen. I think we've got a big fan, Mark, of the evidence standards in Ashlyn, who said they're incredibly useful. And I think that's coming through sort of loud and clear. I think what you've done between you panel members is you've sort of boiled this down and made what seems like quite an amorphous, confusing thing actually quite simple if you break it down and chunk it up and you look at a proportionate and pragmatic approach. So thank you all for helping us find our way through this this topic and make it so simple, actually. So we've got one more final session, and actually I think it was Abigail that flagged up the issue about onboarding and engagement. And actually you can't generate any evidence if people aren't using the digital tool that you've developed. And one of the things we've really noted at Mindwave is how often the importance of onboarding, that's bringing users onto your platform and retaining them and engaging them, is often forgotten about, but is such an important part of that sort of design and development cycle. So in the final session, we're going to bring in some experts from academia and industry and the NHS to really think about how we do onboarding, acquiring and retaining users as well as we possibly can. But for today, Kat and I would like to just thank our amazing panelists, thank everyone who's joined the call and for the great conversation and resources that you've shared. People are asking, will the recordings be posted? They will. We've just got to get them sorted, and we'll put them on the Mindwave YouTube channel, and we'll find a place for them at Sheffield University as well. But yes, thank you so much for your contribution, everybody. Have a lovely day, and hopefully you'll join us for the final session as well. So thank you very much, everybody. Goodbye.
Thanks.
Bye. Thank you.